Good evening, everybody. We'll go ahead and get started for the evening. Sorry to hold everybody up. Do I have to use this too?
Use this and use that to go forward.
Okay, great. I guess it's good to see that everybody's social networking. So that was one of the goals of our chapter. So I appreciate that. Now, good evening, everybody, and welcome to the bi-monthly meeting of the Southeast chapter of the Society of Critical Care Medicine. My name is Prasad Abraham, and I'm the outgoing president for the Southeast chapter. Before we got today's meeting started, I wanted to kind of review some of the highlights of what we've accomplished as a chapter over this last year. So I'm going to spend a couple minutes reviewing that real quickly. Okay, sorry. Technical difficulties. All right, so in terms of membership, two things we wanted to achieve was improve our diversity and as well as the numbers of our chapter membership. And we're able to tackle both these goals this last year. We grew our membership by over 20%, and we've added 3 new disciplines to our chapter as a whole. So we're really excited and welcome the new people to our group. In terms of networking, one thing we want to do is provide more opportunities for our chapter to network with other disciplines and other people from different institutions. So one of the goals we set out last year to do was to host one of our bi-monthly meetings at a different site. So last year in August, we hosted Dr. Wes Ely at the Emory campus, which was a very successful meeting. We learned a lot about sedation and delirium in the ICU. With regards to education, one of the goals was to offer CE for all our programs last year, and we were able to achieve that for both our nursing and pharmacy colleagues. We're still working on getting that CE credits for our physicians and registered dietitian colleagues as well. Another goal we wanted to do was improve our collaboration, or actually collaborate with the Emory group in terms of helping with the Southeast Critical Care Summit that happens every year. This past year I had the privilege of serving as the co-chair for that committee and help with some of the programming. And one of the direct changes as a cause of our direct involvement with the summit was that we're able to actually host these poster presentations at the summit this last year for the first time. We had 5 poster presentations. So again, it was a tremendous positive turnout, and the committee actually that organized it was really happy with the turnout and wants to hopefully sponsor more posters in the years to come. So again, very positive outcome there. In terms of research, one of the goals we set out last year to do was get one research project accomplished as a network. The project was involving or identifying ethical issues in the critical care environment. Unfortunately, we ran into some roadblocks with that project, so as of now, we're on the early phases of that project. We just got IRB approval, and we're currently validating the survey to hopefully roll out to the chapter later this year. With regards to communication, we set up a goal of establishing better communication with you as members by using our website and Facebook more effectively, which we've done a good job of getting the information out there as it comes along. We're definitely getting more and more information to you guys through these electronic media. We're working on consistency, but I know we're going to get there sooner. In terms of some miscellaneous goals we had for last year, we wanted to kind of improve our public visibility, if you will. So 2 pilots that we set out to achieve. First one was Project NextGen, where we wanted to expose high school students to the critical care practice environment, kind of give them insight as to what happens in the ICU. So we piloted this program at Grady this last year. We had about 10 high school students participate. The response is overwhelmingly positive. They're really excited to see not only the ICU environment, but to see how the different disciplines interact as a team to achieve patient outcomes. So that was, again, a positive impact there, and we're hoping to roll this out in the years to come to different hospitals. And it's a pretty easy thing to roll out, actually. The sepsis campaign, we were hoping to start a Georgia-wide sepsis network, if you will, similar to that in Michigan and New York, to kind of help manage and really target sepsis patients throughout the state, and as a state really work towards helping everybody achieve that goal of treating those patients early, identifying them early, treating them early with the appropriate care. Unfortunately, we were unable to make much progress on this goal. The Georgia Hospital Association does have a core network of people that they're trying to develop some protocols and stuff with right now, and hopefully we'll be able to come alongside them in the next couple of years to help achieve that goal. But we're still working on that. We set up a goal to apply for the chapter award that SESCCM offers every year, and we did apply. Unfortunately, we did not win it this last year. New Mexico did, but that's okay. I'm pretty confident with our new leadership. Next year, we'll definitely have that. No pressure, Kat. And finally, in recognition of Barbara McLean, for those of you who know Barbara, she was awarded the Norman J. Shoemaker Award 2 years ago at SCCM, and so in honor of her and critical care nursing excellence, we actually developed an award after her. It's a Nursing Critical Care Excellence Award, and this last year we offered it for the first time to Ms. Carolyn Holder, who is one of our nurse specialists over at Emory. So again, some of the things we kind of accomplished over this last year. So just kind of looking at it from a report card standpoint, we've definitely made positive strides in terms of membership growth, networking, education. We're working on our research. Again, like I said, a lot further off than we wanted to be, but we're working on that. Hopefully we're going to get better with our communication as well as these public outreach projects that we've set up as a group. So this is kind of just a quick synopsis of what we did over this last year. And so I just want to extend a tremendous thanks to the chapter leadership and all the committee members that volunteered to help really make all these goals achievable and possible. This is truly a culmination of a team effort. It's not really any one individual that accomplished these things. And I just want to say, as the chapter president, it's been my privilege to serve with you guys these last 2 years. It's an absolute honor. And I think the one thing that I'm really, really proud of today is the fact that I'll be able to hand this off as a chapter to much better and much capable hands than my own. So without further ado, I want to introduce our new chapter president, Dr. Kathleen Chester.
Can everyone hear me? Okay. So first of all, I want to start by saying thank you to Prasad. Basically, with his vision, leadership, and mentorship, it was possible to revive this chapter 2 years ago from basically nothing, just some members that were paying dues but not really reaping the benefits, to what we see in the room here today. Plus, we're really excited to have our first remote live viewing, so we have some attendance in Memphis as well. So thank you everyone for your participation, and thank you Prasad for your leadership. I also want to announce that our incoming president-elect, she was previously our secretary and did an excellent job, but Marina Rabinovich, if you could please stand up, she's our president-elect. Ashley DePriest is a dietitian who works here at Grady. She was not able to be present today, but she is moving into the role of secretary. And then Megan Van Berkel at Methodist in Memphis, she's moving into the role of treasurer. So we're really excited about this group, and we hope to continue to strengthen and grow our chapter. So with that being said, I quickly want to run through some goals that we have for these upcoming years. Okay. And then we'll get to our speaker presentation. So for membership, we want to try to increase the overall membership by 10%, increase the non-in-training membership by 10%, and increase physician membership by 5%. For networking, we'd like to hold at least one bi-monthly meeting at an institution besides Grady. So last year we were able to hold a meeting at Emory, and we'd like to hold a meeting possibly at Emory Midtown, maybe even Wellstar, Kennestone, or some other place if anyone has any recommendations. We'd like to provide more online viewing opportunities for every meeting and possibly have additional remote viewing locations. And then have at least one out-of-state institution involved as a satellite campus. We also would like to hold at least one meeting at an out-of-state site this year. For education, we'd like to work towards offering CME credits for at least 3 meetings to physician members, offer CE credits to at least one other discipline besides physicians, nursing, or pharmacy, and offer FCCS this year. For research, we'd like to complete the ethics study, identify the next research project by fall of 2014, and increase the number of poster presentations at the Southeastern Critical Care Summit. And for communication, we have been working really hard to restructure and reorganize the committees, and we'd like to begin holding scheduled monthly conference calls with all the committee chairs, just to make sure that everyone's on the same page and to make sure that we're meeting these goals that we're working towards achieving. All right, real quick before we get started, I definitely want to thank our industry support in the back, Hospira, Genentech, Boehringer and Ingelheim and Janssen, and also Arbor Pharmaceuticals. Thank you so much for your support in making this possible. Okay. And without further ado, I'd like to introduce our speaker, Dr. Gretchen Brophy. Dr. Brophy is a professor of pharmacotherapy and outcome sciences and neurosurgery with Virginia Commonwealth University School of Pharmacy, Medical College of Virginia campus in Richmond. She is also a neurocritical care clinical pharmacist at VCU Health System. Dr. Brophy received her PharmD from the University of Arizona College of Pharmacy in Tucson, and her postgraduate training includes residencies in critical care and pharmacy practice at the University of Kentucky in Medical Center in Lexington. Dr. Brophy's research interests include effective treatment strategies for patients with brain injuries and stroke. She is an active member in the Society of Critical Care Medicine and the Neurocritical Care Society, and has been heavily involved in guideline development, including the 2012 guidelines for status epilepticus, which makes her the perfect speaker for our topic today. So I'd like to welcome Dr. Gretchen Brophy.
Okay. You're welcome. Thank you. Thank you all for having me today. See, we got the back row crew hard at work back there, as usual. I wanted to make this very informal today. So as we go through, please, if you have questions, feel free to jump in, comments, whatever you want to talk about. If you, stop me, and I'd be happy to go through some things. I wanted to talk about status epilepticus. As Kat was saying, we created the guidelines through Neurocritical Care Society in 2012, and I was privileged to work with a great group of people to pull that together. So I wanted to bring some of that data to you, and also bring some of the data that we pulled together from our Neurocritical Care Society pharmacy group, looking at the treatments of status and the etiologies of status that are really happening in the real world today. So I'll present some of that data. Wanted to go through the definitions of status, because we did change those sort of officially in the guidelines that we created. We wanted to look at the time frame for treatment of status. We're trying to push that quickly so that we can really get our patients under control easily. Wanted to also go through the pharmacotherapy and monitoring and describe some treatment options, and I have a patient case that we can go through at the very end. So let's first start off with talking about status and the definition of status. And this is something, and it's so funny because I kept seeing SE on all of the slides previously. This isn't Southeast chapter of SESCCM. This is status epilepticus, my SEs. So as we go through that, you'll see this throughout, so don't get confused. But anyway, status was something that we used to define as 30 minutes or more of continuous seizure activity, and we changed that definition because really clinically, if you're in a place that healthcare workers are and we're right there observing it, that's way too long, okay? The longer you go, the worse off you're gonna be, so we need to stop it quickly. So we said within 5 minutes or more, if you have continuous clinical or electrographic seizure activity or recurrent activity without recovery of consciousness in between, you're in status epilepticus. So what we need to do is stop it quickly, because the less likely you are, the longer it takes you to stop status, the harder it's going to be to treat it. Okay, you become refractory to these drug therapies due to changes in receptors, which we'll talk about, and you have a greater chance of neurological damage and increased morbidity and mortality. So we have to move this forward. It's a medical emergency, just like other things such as cardiac arrest or brain attacks or strokes. And then we have to deal with this as quickly as we can and try to stop the activity. So why is status happening? Why are these seizures, these repetitive seizures happening, and what can we do about them? Well, I just want to go through a bit of pathophysiology here. I think, is this a pointer? No, maybe. There we go. All right. Actually, I'll use my mouse. Oh, no, I won't use the mouse. There isn't one. For the different receptors, just looking at the receptors, I'm a visual person, so I like to have lots of slides and pictures to represent what's going on. So in this is the neuron, and you got the presynaptic and postsynaptic receptors. And what you can see there is before status happens, we have a pretty neat looking picture, so to speak. We have GABA and we have glutamate, but a lot more GABA, and we have GABA receptors that function and keep everything in balance for the excitatory and the inhibitory phases. But what happens when status continues on is you have a change in these receptors, and this is what makes treatment a little bit more difficult the longer it goes on. So as you have the GABA again and the glutamate release, you have the internalization really of these GABA receptors, and so you don't have as many receptors for the stimulation of the GABA receptor, and so you have a lot more glutamate. So really what you end up with is this imbalance between the excitatory and the inhibitory effects in the neuron. Okay, so we got to try to balance that out so that we can make sure that, you know, we're trying to stop the damage that is going to occur. What causes status? There are a lot of different things, and this is one of the things up front that we need to think about, because whatever the underlying cause is, we need to try to treat that. If we're not going to stop the status, perpetually continue, I don't know, searching for the word here, we're not going to be able to halt status altogether if we don't treat the underlying cause, right? So we got to think of the acute processes. So what can cause it? Metabolic disturbances, infection, CNS infection, stroke, head trauma, etc. And then chronic processes. Pre-existing epilepsy is one of our big probably issues when you think about it. The patients that are on anti-epileptic meds and stop taking their medicines, especially in today's economy, a lot of patients can't afford their drugs, so they're stopping their medications, and what happens is they come in with status. Okay, anticonvulsant withdrawal there is what you're going to see. Alcohol withdrawal as well. Tumors, illicit drugs. I don't know about here in Atlanta, but I know we have a lot of recreational drug use in Richmond, Virginia, and they're creating lots of new things that they come in and we're like, what is that? And you know, you never know anymore these days. And you got a lot of psychological changes that occur with these psychomimetic drugs. So we always got to think about that as well. So think about the underlying cause, try to treat it so that we can help then the patient stop the seizures. You also need to be aware what drugs the patients are on. I rounded this morning with Kat in the neuro unit, and it was really good to just sort of see how you guys do things here. And one of the things you notice is the patients that do come on the unit, they may be on a lot of meds at home that will actually lower seizure threshold. So they may not be seizing now, but if they are, they've now got a head injury potentially or some kind of CNS injury, and they're on these drugs, and now you've got this combination that may lower your seizure threshold. So just keep in mind a lot of the different drugs. Theophylline we don't use a whole lot, but we had a patient on that today. It was interesting. Carbapenems, fluoroquinolones, you may not think of that very often, but you have to dose adjust the fluoroquinolones, because if you do not, they will get toxic and they can seize. Antidepressants as well, a lot of tricyclic antidepressants. Lithium, clozapine, and cyclosporin are some other common ones. So think about what meds they're on. Again, try to treat that underlying cause. What's the damage that occurs if you can't stop these seizures? This is a great little flowchart, I think, from Larry Hirsch out in California. He had a paper they published on status epilepticus in 2013, and I think this sort of gives you, again, a visual of what happens over the minutes to hours to days when a patient has status epilepticus. And you can see it from the various different types: neurophysiology, motor, systemic, brain metabolism, and brain damage. And as you start in that acute seizure phase, you can see the increase in the NMDA receptor or glutamate excitatory and the decrease in the GABA. Okay, so from the neuropsych standpoint, the motor, you get the generalized, usually convulsive seizures. And what happens? You see their heart rate go up, their blood pressure go up, glucose will go up, lactate will go up, cerebral blood flow will go up, glucose, oxygen changes. Brain tissue oxygenation, if you monitor that here in the neuro units, you'll see that start to change. And as you keep going, then you see this other secondary phase. It usually takes about 30 minutes or so, and you start seeing these changes. And then you'll see, like, instead of this compensatory phase, you'll see this decompensatory or decompensation phase. And then you'll see the changes going in the opposite direction. So you'll see the decrease in glucose, decreased lactate, decreased brain oxygenation. And if you can see the lines here for the cerebral blood flow, it starts going down as well. And then the glucose and oxygen tend to stay there. Brain tissue oxygenation goes down and brain glucose goes down during that phase. So you're really seeing more and more damage that's occurring as you're not stopping these seizures. And then you get, as you go down days here and more time elapses, you can see that with convulsive versus non-convulsive, the damage is higher with the convulsive, not as much with the non-convulsive, because you don't have all of the energy expenditure with the non-convulsive, but you still have the increased risk of brain damage. So it's very, very important to try to stop these seizures as soon as we can. The underlying complications that you see after all those pathological changes, the hyperthermia, lactic acidosis, rhabdo, hyperkalemia, arrhythmias, aspiration, you name it. It just goes on and on. So a lot of the complications we see post-status or during that period of status are things that we won't see if we can stop it early. So again, all goes back to trying to treat it and treat it quickly. Okay, so our goals of therapy for our respiratory therapists out there, we got to keep them breathing right, ABCs, airway protection, supportive care, termination of seizures, prevent the recurrence of seizures, because even though you've stopped them doesn't mean they're not going to come back, right? Management of those underlying causes and management of the complications that we get along with it. So what did we do from the standpoint of, trying to figure out what are people doing for status? We know it's a bad thing if it continues. We need to stop the seizures as quickly as possible. So our neurocritical care group actually did a survey, and we ended up with several sites and 150 patients, and we looked at who was diagnosed with status over this time period, just to get a general idea of what type of patients we're seeing in the real world and what people are actually using. And what we found was presumed etiology, as you can see here. Blue bars are no seizure history and red bars are seizure history. So presumed etiology of epilepsy, AED noncompliance, you can see is there as high, TBI, brain tumors, ICH, stroke, etc. So you had a gamut of different types of etiologies of the status with underlying really CNS injuries or, again, epilepsy where they've stopped taking their meds was one of the biggest issues there. Ischemic stroke as well and ICH, we see those more so with ICH than ischemic stroke tend to be. Subarachnoids have a very low rate tumor, brain tumor sometimes, that's the presenting symptom is a seizure or status. So looking at the different etiologies, these sort of make sense. This is what we thought we would see and what we feel like we probably see in our units, and this is what we saw across the US. So what were people given? How many drugs were they given? Well, we've got on this graph 1 to 6 or more, okay? So only 7% got only one drug, 2 drugs, 23%, 3 drugs, 29%. So when you look at this pie, you can see that at least 3/4 almost, or 2/3 of this pie really at least got 3 drugs, somewhere in there, 1, 2, or 3 drugs. Okay, and then you move into those ones that we can't stop. So 1/3 of the patients we can't really stop, 2/3 at times it looks like we can actually stop with at least 3 agents. Okay, but we go on and say what drugs did people really use? And we saw that there's a variety here too. Benzodiazepines were sometimes the first drug, sometimes phenytoin, sometimes levetiracetam. You can see we've got several drugs listed here at the bottom that people, it's a gamut. It runs a gamut. There's no real standard of care when we did this study to say what are people using. And then once they got past that first or second drug, what are they using for drug 3, 4, 5, and 6 or more? And so the drug 3 was the blue bars here, and you can see most people for the third drug, another benzo, phenytoin, levetiracetam, and then we got lacosamide and propofol, and then topiramate were sort of the bigger third drugs. Then we got to the fourth drug, valproate came in, barbcoma, as well as those others we just mentioned, and then again you've got a variety of things going on. So it sort of comes to show you that we really didn't have good guidelines or we still don't have a lot of good data to say what should we be using for status epilepticus. But this was sort of proving the point that everybody does what they feel they like or they're comfortable with, and that's sort of what was happening. So we decided we really needed to try to bring some people together and try to come up with some guidelines because there's not good data out there, and because of that, this is what happened, what you just saw. People are sort of all over the place. And it's just sort of on a whim as to what you want to do in attending specific. So we said, okay, let's go ahead and write guidelines, even though we know there's a lack of data out there, and at least we can pull some experts together and try to come up with some recommendations as to what we should be doing. So we wrote these guidelines internationally as well, and we included some of the pediatric folks as well. And we tried to come up with different guidelines so that we could all sort of use the same terminology, the same maybe common data elements as we look through and evaluate our patients. And as you do research and things, think about these definitions, and the more we can keep these consistent, the better the data we will have so that we can then compare our data between sites. So again, we talked about the definition, which I told you earlier was the 5-minute or more, and we said that's a very strong recommendation with high or moderate quality evidence. We said status is either convulsive or non-convulsive. and you need to have that non-convulsive, the EEG as a reading for that non-convulsive status. Refractory, we said, should be defined as status that does not respond to standard treatment regimens. This is different, okay? We used to say 60 minutes or more, you're refractory, with no talk about the type of treatment or how many you got. So now we're saying we need to respond to treatment. If the patient doesn't respond to first or second drug therapy, you're now refractory, okay? And benzo is your first drug. And then we need to diagnose the etiology again. We talked about that. So here's a little algorithm sort of running you through it. Pre-hospital, then we went from, we always say first line, second line, third line therapy. Okay, this gets confusing because then people don't really know, well, is your first line several doses of a benzo? Or is, what is it? So we're like, okay, we're going to change the terminology here and get people to think about this differently. So we also went with emergent, urgent, and refractory therapies. Okay, so you start with your emergent therapy, then you go to urgent control therapy if you're seizing, if you controlled the seizures or you didn't control the seizures in the status on the benzo. And then if you can't control it with the urgent, then you're refractory and you move down that pathway. So we're going to go through this just and talk about each of these therapies and the evidence behind that. So I have on this slide 0 to 2 minutes, and I have some following slides that have times. And these times are not absolute times for anything. It's just clinically, what do you think we can really do in what time period? And that's sort of what I put up here. So 0 to 2 minutes, we're going to be doing supportive care for these patients with status. We're going to do airway, breathing, circulation, and we're going to get that emergent control therapy on board. Okay, so that has to do with our finger sticks. We're looking at fluid resuscitation, nutritional issues, and blood pressure control. Okay, we're also going to look at what labs do we need. Get those all ordered while we're doing the workup. But while we're doing this, we're giving our first drug. Okay, we're not going to slow ourselves down. We're going to do all this at the same time and decide what we need to do. So rapidly and sequentially, get everything done and halt the seizures with the treatment. And we want to make sure we're doing the critical care monitoring of these patients as well, right? Because we just talked about the pathophys and all those different things that can happen over time. So you have to make sure you have supportive care for those things as well, so the patient doesn't have more complications from underlying problems from the status. Okay, so after that first 2 minute period, you got your emergent therapy on board. That emergent AED is hopefully starting here. And again, benzos is the drug of choice. Lorazepam IV, midazolam IM, or diazepam PR if you don't have any other access. And again, our goal is to stop the seizure. Okay, the definition of stopping the seizure is clinical or electrographic, and usually different places will have different types of goals for the electrographic seizures, and we'll talk about that a little bit in a minute. So for the initial emergent therapy from the guideline standpoint, we said there were strong recommendations and high or moderate quality evidence that benzos, again, we just talked about, that should be given emergent initial therapy first. Lorazepam IV, midazolam IM, as I said before, and then if you can't do that, then the rectal. After you get that on board, you're moving to urgent care, urgent therapy, urgent control therapy. So urgent therapy is recommended for the drugs that had the highest data, which was fosphenytoin or phenytoin, valproic acid, and levetiracetam. Why did we come up with some of this data? Were you guys a part of the RAMPART trial? Do anybody? Yeah, here at Emory and Grady and Emory? Okay. This trial we also were part of in Richmond. And so when we got to, this is the emergent treatment strategies. We're talking about benzodiazepines here. This is the rapid anticonvulsant medication prior to arrival trial, so RAMPART. And what they did for this trial is looked at termination of seizures prior to ED admit or an arrival, and they did two different dosing strategies, IV lorazepam or midazolam IM, being an auto-injector. Okay. They looked for termination of seizures, and what they found was without rescue therapy, midazolam 73.4%, lorazepam 63.4%. Now it's statistically different. So actually the midazolam works for the stopping of seizures pre-hospital with the IM delivery. The time to active drug administration, 1.2 minutes versus 4.8 minutes for lorazepam. Okay, so we got it on there faster, and then safety looked very similar. So what their conclusion was midazolam IM is at least as effective and as safe as lorazepam IV for that pre-hospital. So this just gives you an idea of what they saw and how they broke it down, because when you look at the different ways that we're giving it. Again, this was an auto-injector, which isn't commercially available right now, but hopefully will be soon. And what they looked at, if you look at the first box here, time to active treatment, from active treatment to cessation of convulsions. And the IV lorazepam is the first set of boxes, and the IM midazolam is the second. So you can see here, from time to active treatment to cessation, the lorazepam was actually shorter. Okay. When you go to the time from opening the box to active treatment, the midazolam was shorter because they basically took out the auto-injector and gave it. So that was a shorter period of time. So the time from opening the box to cessation of convulsions, how they got that statistical difference was basically the midazolam was then faster from the time of opening to the end of convulsions, even though the lorazepam worked quicker. Does that make sense to everybody? So you had to think about what we sort of try to, or sometimes miss, and the nurses know this specifically because they're always the ones giving these drugs and getting them out. It takes time. It can't be like, okay, give lorazepam and it's done. They got to go to Pyxis or go to wherever you're going to get it, bring it back, pull it up, give it to the patient over, 2 milligrams per minute. So you got 2 minutes as you're giving it. And so it takes a little bit of time to get all this done. And so that's what they also found in the pre-hospital administration. Okay. And then this is just a picture of the auto-injector that they did use. They used a very concentrated amount of midazolam for this injection. And like I said, they are working on this, but I haven't seen any. Does anybody have any information as to when this might be out? Somebody? Okay, so I know they're working on it. And I think you've seen probably in the news, lots of auto-injectors are coming available for a lot of different things now. So hopefully this isn't far behind. That was the pre-hospital comparison trial that was recent. And then we only have really one really good comparative trial of anti-epileptics for generalized convulsive status. Unfortunately, this was from 1998, okay? So I don't know if some of you were even born, who knows at this point. Everybody, I feel too old anymore. But this study was done in patients at the VA, and it was a randomized double-blind multi-center trial in 500 patients. They had overt or subtle, which is non-convulsive status. And what they compared was the lorazepam at 0.1 per kilo, phenobarb, diazepam plus phenytoin or phenytoin alone. And the doses that they used were adequate. They were all good dosing strategies to sort of compare them. They all should have been effective doses. So what did they find in this study? Well, when they looked at the different treatments and the success for treatment, you can see in the blue bars for the overt or convulsive status epilepticus, blue, you see that lorazepam had the most successful treatment, 64.9%, and you titrate and you go down as you go through the list there. And then for non-convulsive status, they all look really pretty similar, again with the lorazepam working and the phenobarb working better potentially than the diazepam phenytoin combination or phenytoin alone. And this is, again, first drug on board to stop seizures. So, again, emergent therapy. And so the statistical significantly different differences were found when you looked at the lorazepam versus the phenytoin. So, again, this is where we get the data to go back for emergent therapy, saying benzos are first line. Okay. Looking at the pharmacokinetics of the different agents, I think this is important, too, because you got to think about even though they're all benzos, lorazepam, midazolam, and diazepam, they do have different properties that will therefore then make the drugs affect quicker in some instances and longer in others as well. So looking at lipophilicity, diazepam and midazolam have a very high lipophilicity, whereas lorazepam has a low lipophilicity. What does that really mean besides trying to tie my tongue up here? That means basically that the high lipophilicity, your brain's a lipophilic organ, right? So the benzodiazepines will get into, they like high lipophilic organs because they can quickly go in. So the diazepam and the lorazepam will the diazepam and the midazolam will enter quicker than the lorazepam. However, they also redistribute a lot quicker out of the brain. Whereas the lorazepam takes a little bit longer to get in. So instead of like 2 to 3 minutes for the others, this takes maybe 3 to 5 minutes for the lorazepam to get in the CNS. And therefore, it takes a little bit longer to take effect. However, it lasts for about 12 hours. Okay, when we used diazepam, which used to be our first line agent years ago for status, you only had about a half-hour window. Okay, and then you had to have an anti-epileptic on board because the diazepam was no longer effective. because of that rapid redistribution out of the brain. Okay, so that's where you sort of see the half-lives here, thinking about the intracerebral half-life, the amount of time. So lorazepam gives us takes a little bit longer, but it gives us a lot more time to get the other drugs on board. Okay, and then penetration-wise, again, the diazepam and midazolam come in and out very quickly. So here are the other information that you got from the guidelines based on the evidence. And you can see for each drug name there, lorazepam, the evidence was a class 1, a level A, so good evidence in randomized controlled trials. Same with midazolam, and then diazepam had the 2A, level A recommendations. And you can see the dosing here. One thing that people get hung up on, I think, is the lorazepam dosing, because everywhere, and even in Dave Tryman's study, they had the VA Cooperative Study, they talked about 1 milligram, 0.1 milligram per kilo lorazepam, and they're like, okay, but everybody we have now is 100 kilos. That's 10 milligrams lorazepam. Do we really give that? No, not really. Okay, so what we did in the guidelines is say clinically, what are we comfortable with and what are we really going to give? So 4 milligrams is sort of our comfort zone, I think, as well as probably effective. It's probably going to be effective. And again, you got to think about the treatment doses that we know and what we use. Even though Tryman's study in 98 was 0.1 per kilo, lower doses weren't tried in that study. So maybe we don't need that high of a dose. And what we find is probably 4 milligrams is effective, and it will stop most seizures. If you do need to repeat it, you can repeat it one time. And so 8 milligrams would sort of be your max dose. Is that what you guys do here clinically? Yeah. Okay. All right. The other thing you got to think about, we usually have to give the lorazepam a little bit slower, like I said, over 2 milligrams per minute, because it's got propylene glycol in it. So if not, you're going to drop the blood pressure really quickly, and I'm sure the nurses know that pretty well as they give it, and they have to give that a little bit slower. Okay. All right, so once we moved on from that emergent treatment, we go into the urgent control therapy. And this, again, is probably somewhere within 10 minutes of hopefully giving, the start of the status, the diagnosis of the status, right? And once you want to, and getting that emergent therapy on board. So we have a lot of different options here. And then some of the main, most of the literature, I should say, is more closer to the phenytoin, phosphenotoin valproate. It probably has the most data. And then you can see there's a little bit more data for the others, but there are a lot of just case series and case reports and not really controlled trials when it comes to these other agents. But what we want to do is stop the seizures and keep them controlled, right? So once we did the emergent therapy, we need to move it on. Now, because we have a lot of these different options, again, I want to go back and just go through the pharmacology a little bit. Again, visually, I think it helps to think about the neuron and where the different agents work. And knowing that sometimes we'll try a combination of different agents just so that we know that they hit on different mechanisms. By doing the different mechanisms, hopefully we'll have a little bit more synergy or a little more additive effect. However, there have also been studies looking at drugs that work just as a sodium channels, and trying to stabilize those sodium channels. And even though you use 2 drugs in that same category, they still seem to work and don't seem to antagonize each other. So just looking at the groupings here, you can see one of the big groups we use is the sodium channel blockers. Again, they don't completely block. They more, keep it from transitioning onto status and keeping that flow, sort of stabilizing those membranes and slowing down the channel. You got the calcium channel drugs as well as the calcium channel blocking drugs here. And then we've got all of our GABA activity. And we'll talk about a little bit more of that in depth when we get to refractory status. And then also the glutamate receptors, the NMDA and the AMPA receptors. We have some of the new drugs, the perampanel is a newer agent that came out last couple of years, but now it's having problems as well. All these new drugs that we thought were going to be good, beneficial things, now they've got a lot of side effects that are sort of life-threatening, and we have to worry about them. So we may or may not be able to use these in the future. And then our potassium channels was one of our new drugs too. Our potassium channel opening agents is ezogabine. Again, got some issues with visual or in blue skin, blue pigment, and things going on there. So it reminds me of Smurf syndrome with amiodarone years ago. I was in Arizona, so I saw a lot of purple people. So I'm not sure if that's what's going to happen with this ezogabine or not. But anyway, think about the different mechanisms and then pick your agent based on your patient and based on the side effects that you would expect for each one. This again is just another chart showing the different principal mechanisms, and it sort of gives you an idea of how many do we have in each different category that you can sort of combine and try to make a good therapy to pick for your patient. All right, so these are the data for the different agents. Valproic acid again and phenytoin had the level 2A, class 2A, level A, and level B data. So they had the most randomized controlled trials, so to speak, with those. And then you got into also the midazolam infusion. There was some studies looking at that. I don't know that many of us use a midazolam infusion second line or that urgent therapy, as I said. But there actually is data for that, so some people may actually be using that right after that benzo load to stop the seizures. And then phenobarb and levetiracetam have level C data. And I had little boxes, but so much for the boxes. There we go. So the other thing to think about is when the patient is in status, you have to monitor them. How are you going to monitor them? Probably not a 30 or 60-minute EEG, right? You probably have to go for that continuous EEG in these patients with status because they come in and out of status. And if you don't, you can miss up to 50% of the patients in non-convulsive status if you don't leave the EEG on. If your patient is comatose, you probably want to leave it on for 48 hours, or you will miss a large percentage of those patients because of the changing, because they will go in and out of status throughout that time period. But we want to get the EEG on. We want to get it on quickly. So within an hour is what we set as a goal. I know that may be difficult for many institutions with resources and texts and different things. And I'm hoping technology will keep up with us and somehow we will be able to get better technology for these EEGs where we can get them on easier and quicker and reliably read them in that short period of time so we can then titrate our therapies to what we need to get done. When we do, I said, put them on there for 24 to 48 hours. And then, so we've treated with emergent therapy, then we went to urgent control therapy. Okay, now we've got refractory status. What is that? Well, only 20% of patients with refractory status, when we get there, our drugs don't tend to work as well, right? Because we talked about that in internalization of the GABA receptors. So about 20% of our patients will really not have the response we're looking for once we get to that point. So we really have to then move on. And that's where we changed the sort of thought process. Instead of going to giving another dose of phenytoin or giving phenobarb, or let's try levetiracetam. If these patients are truly in status and you have an airway that's protected, you need to move on to a continuous infusion agent. Okay, so we're not waiting. So this could be something that's, boom, 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 within 30 minutes you're on the drip. Okay. So these are the different agents that we tend to use. Midazolam, propofol, pentobarb are our big workhorses, and that's what we also found with most patients, again, in the studies that we looked at, and also in the expert group where that was pulled together for the guidelines. However, if the patients aren't intubated, you do have a lot of other drugs that you can use that aren't going to suppress the respiratory drive. Okay, so levetiracetam, lacosamide, valproate, topiramate. So you have some other options there that you can possibly use. And thinking about in the ICU always, what are our IV options? Well, we have a lot more now than we ever used to, so which is really nice. And we got levetiracetam, lacosamide, phenytoin, valproate, phenobarb, pentobarb once we get there, and obviously our drips. So we've got a lot more options than we used to have, which makes it at least gives us some more drugs in the arsenal to use when we don't have PO access or NG access, and we need to get this done quickly. The evidence for refractory is very, very weak. It's 2B, level B or C, as you can see here. Again, most of the data is with midazolam, propofol, and pentobarb, and then thiopental, which is what we used to have, but it's no longer available. And then valproic acid actually has a lot of data as well. It's a lot of studies from India, however, so, but they did do them pretty well in the studies that they did do, that they showed success with it. I think one of the things you have to think about for the valproic acid is issues with thrombocytopenia, incidence of, so you have the risk of bleeding depending on what's happening with your patient, liver failure, because it's hepatotoxic. Your ammonia levels can go up. We don't know if they're clinically significant or not, so it's just something to think about as you're watching that. But you can get it on board pretty quickly. I mean, the rates that you usually see is 60 minutes in most textbooks and things, but you can actually give this the infusion now anywhere from 3 to 6 milligrams per kilo per minute. So you can get it on board pretty quickly in a safe short period of time. But just think about the drug and in regards to what's happening with your patient, and think of the side effects and as to any of these that you're trying and choosing, because they all have issues with different issues with each drug. So, and that's what this graph shows. For midazolam, again, this agent is a GABA receptor agonist, so the longer the patient's in status, you may or may not see effect here. It tends to build some tachyphylaxis. It doesn't really have a whole lot of hypotension associated with it until you get really high doses, but it doesn't have propylene glycol like the lorazepam had, so that's a little bit helpful from that standpoint. And as you're titrating, and this is something we always had questions on, is, okay, you put them on a drip, how often do you titrate them? And then when you're thinking about coming off the drip, how quickly do you pull them off once you're checking your EEG and you've got they're out of status? So always think about the half-life of the drugs. And what we had in the guidelines is we told you how to increase it. And for the breakthrough status, you can give them additional boluses of 0.1 to 0.2, and then you can increase the rate. And we've given you rate here, and then we just said like every 3 to 4 hours. When you think about the half-life of the drug, if you titrate the drip for midazolam every 3 to 4 hours, you should be able to tell what's happening. You should be able to reach steady state, hopefully with that dose in about 3 to 4 hours, know where you're at, and if you need to, you can change it at that point. Same way coming off. Okay, so if you've got them controlled and your continuous EEG, you've got whatever your goal is, either burst suppression or no activity, seizure activity, and you're trying to wean them off, give yourself a couple hours as you adjust the dose down. You're not going to cold turkey stop them, because then you're going to have a higher risk of seizing, obviously. So you're going to come down slowly. So give yourself several hours as you adjust the dose down to make sure the patient doesn't go back into seizures before you titrate down again. Okay. For pentobarb, let's go to propofol. We had issues or arguments, not really arguments, but we had conflicting views on maybe what to do with propofol, because as you know, if you bolus someone with propofol, you drop their blood pressure, right? And so with status, you want to stop the seizures as quickly as possible, but you have to weigh it against the hypotension, because you sure don't want to cause any more ischemic risk to the brain or other organs. So some people said, yes, we're going to bolus. They do very small boluses and trying to get the patient under control, and then you can titrate. And I always try to teach everybody, if you're titrating the drip, go by 5 mics per kilo per minute every 5 minutes, okay? It's got a very short half-life, so you can usually titrate this one pretty quickly on and off. You do have to worry about propofol infusion syndrome, okay? So high doses, long periods of time. At these high doses, you can get cardiac arrest, metabolic acidosis, rhabdo, and cardiac failure. So, patients have died from propofol infusion syndrome, or PRIS, you'll hear it called sometimes. Started being noticed in the children at first, and then we've seen adult cases as well. So something to be aware of and try to avoid. Now, all of these drugs, let me go back real quick. Pentobarb, we tend to use quite a bit too, I think, and that's when, we try to save it for last resort. Just because it's got a lot of cardiotoxicity associated with it. It's got respiratory depression. It's got infection risk because it's immunosuppressing. Patients get ileus on it. They get hypothermic because you sort of slow down the brain and the brain metabolism with the drug, and that's why we use it to try to decrease the energy expenditure of the brain as we put them into the comas. And with this drug too, it's one of those drugs that if you look it up, it's got a very long half-life, but it's one of those that redistributes out of the brain quickly, okay? So even though you've turned it down or as you titrate it up, coming off the drug, you can probably change it and titrate it about every 12 hours, because the drug itself is going to, like I said, redistribute quickly, but you're going to see the effects of that coming off as you come down. And again, it would be a very slow taper to come down again, because patients tend to go back into status once we get to this point. It's hard to get these patients off, so you really got to make sure your maintenance meds are on board and there are things that can control it before you come off of these drips. Okay. The other thing to think about is, I said these GABA receptors are internalized, but the GABA receptor, there's 5 different receptors that these drugs work at. And I wanted to make sure everybody was aware of this, because sometimes it's not as clear and you may not think about it. But there's different sites. So the barbiturates, they work at these sites. And again, we're trying to stimulate the opening of the chloride channel to hyperpolarize the cell with the GABA receptors. The benzodiazepines work here on those external receptors. And then propofol and some of our others general anesthetics work more on the inner tracts. So you may see then, maybe that's why the midazolam, if we get to that, refractory treatment, midazolam sometimes doesn't work as effectively potentially as the propofol and the pentobarb, and that's possibly because of the location of the receptors. Okay, so just know that even though we are all saying these are all GABA agonists, they work at different sites because there's all these different GABA receptors, and that may make the difference in the treatment and the effectiveness of the treatment. Okay, and as we're doing this, as I said, we have to do the continuous EEG monitoring. We're going to maintain it. What we said is in the guidelines is to recommend to 24 to 48 hours of keeping them under control, no seizures, whatever your goal again would be, if it's burst suppression or electrographic seizures. Keep them down for 24 to 48 hours, then titrate them back slowly once you make sure you're on the maintenance medications. And then, if you start seeing status again, you're going to stop, obviously, and go back up on the drips and then readjust some of your maintenance meds to try to, again, get them out. And at that point, if you have to go back up, we say leave it for 48 hours before you try to come back off. Okay. During that transition, again, a lot of people have found that, especially if you get to the pentobarb stage, where you're using pentobarb for the burst suppression, phenobarb. Giving the patient phenobarb actually helps with coming off the pentobarb. Obviously, it makes sense. You're still giving a barb and a barb, in replacement. And so a lot of people will make sure that they're on a pentobarb scheduled dosing before they would titrate off, phenobarb scheduled dosing before you titrate off the pentobarb. Does that make sense to everybody? It sounds like you guys do that here too. So, yes.
Instead of using pentobarb, we'll bolus and rebolus.
The phenobarb. Yeah. So he was saying that you tend to use a lot of phenobarb boluses instead of going to the pentobarb. Yeah, very good. Yeah. So the key is stop the seizures, however you have to do it, and minimize the side effects as you're monitoring what you're doing. Okay. All right. So that's what I have for sort of the overview of the guidelines. So I want to go through a case that we had at MCV and sort of see what you guys would suggest that we do. We had Jay-Z, who's a 41-year-old white female with witnessed cardiac arrest. She was seen normal by her mother this morning, but she said she was ill and had vomited and then became unresponsive. The EMS arrived and the patient was in defib arrest and was defibrillated and to normal sinus rhythm. She was down for about 6 to 7 minutes and didn't respond to naloxone, and she was emergently intubated for airway protection. During transport, she became we started having rhythmic jerky movements, and this is time 00. Okay, so here's her past medical history from her parents. Poor health. She's been retching and vomiting, but she has no chronic conditions. She's been taking some ibuprofen. She has her normal social history of alcohol on a daily basis and marijuana occasionally. So alcohol, triple that, whatever she told us, and that's probably what she takes. Vital signs, a little bit of high blood pressure, potentially 142/82 for her. Heart rate's 120. Afebrile currently 37.2. Physical exam 70 kilos. She's 5'4". She's unresponsive and she's shaking. Her blood glucose is 272. Again, the EMS gave her naloxone and emergent intubation, and we are 6 minutes in. Okay, any thoughts so far on what you would want to do with this patient, or anything else you want lab-wise, or any questions about her? Sound like a typical potential patient here at Grady or in Memphis? Yep. When was her last drink? Yep, very important, right? Because we know alcohol withdrawal can cause seizures. Yeah, hypoxia. She's got retching and vomiting. So anything else you can think of? Tox panel would be good. Electrolytes potentially, right? Okay, so different things we could do. All right, so she's here. EMS wants initial treatment. What are you going to give her? What do you choose? How many say A? Raise your hand. If she has IV access, what would you pick? A. Okay. B. If she doesn't have IV access. Yes. C. Anyone? Please don't raise your hand. All right. And diazepam, PR. She won't be your best friend if you pick that one, right? All right, so it depends on if she has a line. We just saw the RAMPART data, right? So IM, midazolam, or IV lorazepam will work. If she does not have access, we don't have the auto injector yet, so they still have to pull up the midazolam and give it IM, right? So at this point, until we get an auto injector, the EMS is probably going to start a line and give her the IV lorazepam, right? Does that make sense to everybody? Okay. Okay. Immediately after treatment, she stopped seizing. Good job. You gave her the right thing. But she didn't regain consciousness. During the ambulance ride, she's now in the ED. The nurses have been successful in placing a peripheral line. So she's being monitored on telemetry and her blood pressure cuff and pulse ox. What pharmacotherapy would you recommend to the ED team at this point? How many say A? Several hands. B? Nobody? C? Got a hand or two? D? No, can't give her PO, right? All right, so our IV choices at this point, we got a line in. She's not conscious yet. I would probably pick A and B. What do you think? Okay, she's still seizing. She's not regained consciousness, I should say. She stopped shaking. So if she stopped shaking and she's there, phenytoin would be the way to go, right? If she was continued to shake, what would you do? Or still have seizure activity? You would probably give lorazepam and give the phenytoin at the same time, right? Okay. Oh, there it is. She's again experienced rhythmic. So that's where I would say we give both. That didn't come up, sorry, till late. So that's what you got to think about. So you're still doing the emergent therapy. It doesn't mean you can't give that second dose of lorazepam, okay? Because if she's still seizing, you still know it's going to take you at least 10 minutes to get phosphenytoin on board or 20 minutes to get phenytoin on board. So you're going to give that second dose of the benzo along with your AED if they are continuing or having a repeated seizure. Make sense? Okay. So we're 18 minutes in. What urgent AED therapy would you also want to start? Pick of the litter. What do you think? Who would like phosphenytoin? Couple of you. Okay. B, valproic acid? No? No valproate for this one? C, levetiracetam? Okay. D, lacosamide? Does anybody try lacosamide for status? First line, second line? Last resort. So like third or fourth drug at this point? Okay, so I think we're all trying different things still, I think, to see what we've got, especially since we don't have any studies yet for that. So I would agree. I mean, any of these probably could be good choices at this point. But again, if basing on the data that we saw earlier, remember valproate and phosphenytoin have the best data or the best evidence out there to say that they're going to control for the urgent control therapy. Okay, so levetiracetam was our other one that had some data. Again, no controlled studies with the levetiracetam though. All right, so JC's clinical seizures have stopped and more labs are back. This is what we have. What do you see that's abnormal here? Our typical patient, right? I'm sorry, I couldn't hear you. Okay, hypokalemic. K is 2.8. I hear acidotic. 722. What else? How's our glucose looking? High, 350s. Bicarb 16. PaO2. Is that good? 56. I wouldn't want to be there. Anything else you see? Lactate, is that normal? 16, not really, right? Less than 2 is usually our normal. How's our liver function? Not too good, right? Our usual ALT, AST, somewhere less than 50 for each of those. So we're at 500 and 174. Billy's a little up too. We know she's alcoholic, so she could have some underlying, cirrhotic disease. She could just have something else going on. Remember, she came in retching and vomiting, and so she may have some underlying infectious disease going on. Her white count's 17. Her glucose is high. All those things would sort of put you into infectious processes. And then you've got hypokalemia. You got to worry about arrhythmias, right? Acidotic. She's not perfusing. She's probably got I'm sure she's got a gap there. So, think about what's going on with the patient, because we got to make sure we're correcting whatever underlying problem we have, plus stop the seizures, right? So she was transferred to the NSICU for further management because Mercury wouldn't take her. No, just kidding. Continuous EEG management was initiated, or monitoring was initiated. She was not clinically convulsing, but she's still in status based on EEG. So how would you classify her seizures at this point? Okay, I hear C, refractory. Okay, anybody pick anything else? How about B, too, right? She's not clinically convulsing anymore. So she's not having any more clinical seizures. So she's gone now from generalized clonic-tonic or generalized convulsive into non-convulsive status. Okay, so we've progressed on. So she's a refractory as well, though, because we've now got her on we've done our emergent therapy, our urgent therapy, and we're still seizing. So now we've gone to our refractory therapy. Okay, so then what do you want to pick for your refractory therapy for her? What would be your choice? Think about all those things we just looked at in the labs we just looked at. What do you think? I'm sorry? Okay, I hear midazolam, propofol, do you do any pentobar, or what about pentobarb in her? What were some things that may steer you away from pentobarb in her? Okay, liver function, because it's liver metabolized, right? I missed that. Cardiac arrest, okay. She just had a cardiac arrest. And it's cardiotoxic at high doses. Okay. Midazolam has active metabolites. Lorazepam doesn't. Should we pick lorazepam? Lorazepam drips tend to precipitate out. It's hard to keep them in solution, but we can do it. And we used to do it a lot, but midazolam has sort of taken over the last couple of years just because it's easier and we don't have the propylene glycol for the blood pressure issues and that. So midazolam, even though it does have active metabolite, and as long as the kidneys are working, it shouldn't accumulate. But with the midazolam too, it's again high lipophilicity, so it tends, the longer you give it, the half-life actually gets longer because it goes into the tissues and then it comes out as you titrate the drip down. So it may take you a little bit longer to eliminate the drug. Okay, propofol's easy on, easy off. Okay, you just got to worry about the blood pressure, right? We talked about that. So lots of different things that we could use, and it's again going to be preference, but think about your patient. Propofol, again, she just had a cardiac arrest, right? Propofol infusion syndrome. She's acidotic already. Probably not our best choice. So think about your patient. Think about which drug would be best based on everything that's going on. And then think about titration. So again, if you picked midazolam, we probably titrate it every 3 to 4 hours. Go, bolus until we can see that EEG is contained. And then as you need to change based on that, you probably take a couple every 3 to 4 hours. You can then titrate the drip if you need to try to achieve your goal. And then coming off again, go slow coming off so that the patient doesn't try to avoid going back into status. All right, so in summary, status is a medical emergency associated with significant morbidity and mortality. Our goal is to abort status as quickly as possible. Goal right now is what we set for everybody in these guidelines is 1 hour to abort status. Emergent therapy, benzodiazepines. Urgent therapy, multiple intermittent boluses. And refractory, the continuous infusion. Move straight to that and get it done and get it halted. Okay, and then do the continuous EEG monitoring so that you know what you're doing. You don't miss that non-convulsive status in those patients that aren't waking up, and make sure you're doing it for long enough periods of time that you know that patient's no longer in status. Think about those maintenance medications as well so that when you're coming off, you feel like you've got it under control so the patient doesn't go back into status. sometimes then it's harder to stop it the second time going back up. Okay. All right, and that's what I have for you. Do you have any questions? Yes, Kat. Yes. Posted. Very good question. Just to repeat it for Memphis, Kat had asked about midazolam, high doses. Sometimes, if they have renal dysfunction, you're worried about, the renal elimination of the metabolite, and sometimes you don't know if they're still post-ictal or if it's the drug. And it's hard to say in a lot of these patients, and you have to think about that, though. So as long as you're thinking about the renal dysfunction and you're saying, okay, it could be that versus just the post-ictal state, then, that gives you one clue. The other thing would be the continuous EEG that you're doing. If you know the patient's no longer in status, you can probably, continue to come down. We don't draw midazolam levels, right? So you would just come down, give it some time, knowing that they're going to be a little bit extended. You may extend that 3 to 4 hour window for titration too. You may go to 6 to 8 hours, or longer in between the titration coming off the midazolam, just to make sure the patient's not going to seize as you're coming down and as they have a chance to clear it. So you may just want to, try to do that a little bit differently. But just keep watching that EEG as well and making sure that they're not having anything that you suspect to be status again as you're coming down. But it's really hard to say. I don't know if anybody else has any other suggestions. Yes, Prasad. Yeah, ketamine, good question. A lot of people are trying ketamine these days if they can't stop the seizures. We used to be very reluctant to go to it very quickly, but a lot of people are going to it a little bit more quickly anymore. I think you just got to look at the hemodynamic of the patient and worry about that. Worry about ICP, things like ICP if the patient has any issues with that. And we do have titration information and guidelines for that as well. We have not used it extensively at our institution, so I can't tell you experience-wise, but I know that there's a lot of case reports out there that people that I've talked to that have used it as success. Have you guys had to use it, and what's your experience with that? Last resort. Yeah. So even one case where you had weeks worth, and it works at the NMDA receptor, so you're trying to get against excitatory and glutamate. The encephalopathic patients, is that who you're sort of trying it in, and those young kids that have some. Yeah. Okay. All right. So I think it sounds like hit or miss. It didn't really work for you, but I think it's people are trying. I should say that. Right. Yeah, I know that they use ketamine a lot more overseas, and when we were developing the guidelines, we talked to our overseas colleagues about it, just to say, how do you usually use this? How do you titrate it? Because they've had a lot more experience with it than we have in the U.S. And we've got a lot of the data that we put in the titration and everything for the ketamine is from in the thiopental when we had that. So, that I think, like I said, I think it's pediatrics is where I think a lot of places, I don't know if anybody's peds in here, but the pediatric kids is where they were using it a lot before, and they started to do it with the adults a little bit more. But I just don't have enough experience to really give you anything for that, any other information. Sorry. So, yes. Very good question. She asked about when you're coming off the patient's in status, you've got them controlled, you're coming off the drips, and you've got like 6 or 7 meds on board probably, right, for maintenance. And which one do you pull off first? I think what we do, at least, I think there's no really good guidance here. But think about your individual patient, just like you were saying. Pick the ones that have the highest side effect profile that are going to be the most detrimental to that patient and try to get those off first. The ones with the most sedation, for instance, if we do a lot of topiramate orally for status, and we, 400 Q6, like big, huge doses. They're not going to wake up on 400 Q6 more than likely. So we have to come down on that, or we're not going to know how they're doing. So, we pick the drugs that we think are going to cause the most problems. We also have to think about the drug interactions, because if you've got phosphonatoin on board, you've got valproate, you've got interactions there with displacement. So you have to look at your different levels. The phenytoin induces a lot of things, so it depends on what you're on. The topiramate, if you got that on, it also induces and inhibits, and gets inhibited. So think about the drug interactions with the other drugs you're on too, because a lot of patients have a lot of multiple comorbidities, and a lot of these are inducers. And so if you're on drugs like thyroid and different things and you're inducing those, that's not helping the patient either. So look at the entire, ask your pharmacist, your brilliant pharmacist here, and see what kind of different drugs they're on, and sort of think about the whole gamut, the big picture, and then pull off those agents, though, based on side effects, drug interactions, and what they're going to be functional on the most. Think of quality of life. These poor patients that have epilepsy, their quality of life is so poor that, try to get them on something that they can take, they can be compliant and, adhere to the therapy, because if not, they're going to be right back in with status. So as you come down, pick the agents, that have the most problems, and is what I would suggest and what we do clinically. Good question. Memphis, if you have any questions, please feel free to type those in. I don't know who's going to read them, but I will let you know if I see them. Anything else you guys do here that's sort of unique for your status patients, or any other? Do you have protocols in place for different treatment options? Yeah.
We have a protocol in place that's pretty well modeled after the guideline recommendations.
Good.
But I had to step out for a second. Did you comment on lacosamide, and where do you put that into your place of therapy, if at all?
Good question. The question was on lacosamide. It's one of our newer agents. It is a sodium channel. It enhances the inactivation of the slow sodium channel, so it works a little differently than the other sodium channel agents. It is IV. It does have a low side effect profile, and it is effective. There is not any really good even case reports. There's some, but there's nothing really good. But we use it, and we tend to use it pretty quickly. So we'll do the phosphonatoin, we'll do the lorazepam, the phosphonatoin, and then depending on attending, we'll usually have propofol on board. It's usually our go-to. And then we will start lacosamide at that point, and levetiracetam, either one or the other, right then, the next drug. Just trying to get different things on board. One thing I'd like to mention, actually ask you guys, because you have a lot of neurotrauma too, right? So one thing we've noticed for the neurotrauma patients is with the levetiracetam, they get very agitated. Have you guys noticed that as well? So we're trying to not use as much levetiracetam in our TBIs. And I'm not sure, but I'm thinking lacosamide may be a better agent for those potentially. But I haven't jumped on the bandwagon for TBI yet and gone with other AEDs. I mean, phenytoin, phosphonatoin is what we use for our TBIs first line for sure, especially with the data with valproate showing that they had increased mortality in those patients, and not sure why. And so we avoid valproate in our TBI patients, and we're sticking with phenytoin in the majority of them, and then if we need to add on, we will. But I think as we get more data, I think it's going to be interesting to see where that comes out, because again, it's got some cardiac issues too, so that'd be the only other thing it can cause AV block. And so I would, that would be the only thing that would limit us, I think, or one of the potential limitations of that agent. So, yes.
In your facility, are they using any trends and notifications and alarms as the patient might switch into status?
For EEG, in regards to alarms, we do not at our institution that I know of have any alarms that go off. We have our neurointensivists, several of them are neurologists and are EEG trained, and so we tend to look quite often, and then we also have our neurology group that comes in, but there isn't any that I know of currently, data where they're automatically reading. They have to download and then read. So, yeah. Right. 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 Yeah, and that's the hard part, I think, and I think it's hard, for everybody too, not just you guys reading the EEGs, but it's all of us trying to treat them at the bedside too, going, because it's like, we need to read, and then we got to read, and then it changes, and then because it's hard, I know it's so difficult because you don't have that baseline, you don't know what they were at, and then when you change drugs, and you don't know what happened at the bedside, but you're trying to read, and we're like, well, but we did that, and then it's this big vicious circle that we haven't quite figured out yet either, as to what the best way to do this. I mean, we have technology that I think we haven't used to its full potential, and we need to advance that technology because we need to have those bells and whistles. We need to have the ability for smart EEG read, where we can get that stuff. Absolutely. It's this whole it's this IT world that's not letting us, because their machines won't talk to each other. They're creating a lot more problems for us clinically, and we're trying to say that. If you guys have gone to SESCCM at the meetings, we're really talking more about that, about how these companies really have to know that the end point is our patient and improvement of our patient. And if they aren't going to create software that talks to each other, they are not helping us clinically. And they have got to do that because we're one person or a team of people, and our brains can't process all this data that comes in, and you have to have all this data to make the best decision. So these IT and software, from the different companies, they have to start working with us in doing it so that we can make these better decisions and get patients treated quicker and optimally. So, yes.
I was just wondering if you could speak to, I had a case last year with a patient that was getting plasma-free and with accident status. I was wondering if you just had any experience with what agents that you would just go to. We had the patients off phenytoin, and we were following applied levels, but they are on Tepra and many other things. But I just wondering if you could speak to that just briefly.
I don't know a lot about the effects of plasmapheresis on the drugs. I'm not sure we have a lot of data on that, but I don't know that it pulls off a lot of the agents. Have you ever seen any data with that, or what have?
We have a patient now that we're plasmapheresing, same situation. I don't know if it's the same patient we're talking about.
Yeah, our concern was just protein binding.
Right, the protein binding. Right, it changes it. Right. Yeah, well, and it's the same sort of with hemodialysis, because if you think about for phenytoin, even if you're uremic, if you have high, your BUN is so high, the urea actually displaces phenytoin, and you're going to have higher free phenytoin levels in those patients. So as you dialyze the patient and you pull off the urea, your free levels are going to go down, but you're not eliminating your drug. Does that make sense? So it changes the level, and so it really confuses people as you do it. And so in those patients, it makes it a little bit more difficult, but you got to think about it. It's not really, your levels aren't changing. You're not pulling phenytoin off by hemodialysis, right? But you are changing because of that protein binding issue and the displacement issues that you're seeing. Yeah, but did you have any comments on this?
No, I was just going to add, just because we recently researched this for our patients, that it seems like there is data to show that it redistributes from the body stores to maintain a therapeutic level pretty much. However, the timing in which it does that has not been trended. So it seems like it happens fairly quickly, but still you may have a period of time when the patient is not therapeutic as it's redistributing. Any other questions?
All right.